this going. All right. Thank you for attending our webinar today. My name is Annie Randolph, and I am a Neuro Resource Facilitator with the Brain Injury Alliance of Iowa. As you will see on your GoToWebinar control panel, you have two options for listening today, mic and speakers or telephone. So if you have trouble listening with either option, please feel free to switch and see if that helps. We will be recording this webinar today, and we will have it archived on our website along with our YouTube page the next day or so. So please feel free to share that after this if you'd like to share with any friends, family members, or other professionals that you work with. Also, we will save a few minutes at the end of the session for any questions you might have. No CEUs will be provided for this webinar. However, a certificate of attendance will be sent to all attendees following the session through your email. So please look out for that. Also, we will attach the PowerPoints for this webinar, and they are attached in the handout section of your control panel. So please feel free to print those off if you would like to, so you can write notes or whatnot. Now I would like to introduce our guest speaker today. Roxanne Kogel is the Director of Iowa Epilepsy Services for the Epilepsy Foundation since May of 2012. She received a Bachelor of Science degree from Iowa State University in 1995 and completed training and testing to become a certified brain injury specialist in March of 2015. Responsibilities for her include overseeing statewide programs, services, and advocacy, as well as providing direct service in central and western Iowa to families, individuals, and professionals impacted by epilepsy. Roxanne also serves as Central Regional Director overseeing 13 states for the Hemispherectomy Foundation on the Board of Directors for the Autism Society of Iowa, an appointed member on the Governor's Advisory Council for Brain Injuries, an appointed member on the Iowa Olmsted Consumer Task Force, and on the Governing Board of Advisory Board for the Heart of Iowa MHDS region. She's very busy. Roxanne's inspiration and passion for helping others with epilepsy stems from the journey with her daughter's intractable epilepsy, which led to a right hemispherectomy brain surgery in 2009 in order to attain seizure freedom. Roxanne was presented the Joanne Kramer Founders Award in March of 2015 at the Brain Injury Alliance of Iowa's annual conference as Advocate of the Year. Least to say, she's a pretty busy lady and she does a lot of important things, and I want to thank her for her participation today, and I will go ahead and let you get started. Thank you, Roxanne.
Thank you, Annie, and welcome everybody participating on this webinar today on seizure recognition and first aid. The Epilepsy Foundation provides many education programs to law enforcement officers, first responders, school staff, school agencies, daycare centers, as well as seniors. And we also travel the entire state providing these trainings at no charge. So we're happy to do this training today with the Brain Injury Alliance of Iowa. See, Annie, I cannot get my screen to advance. Oh, there we go. The objectives of this training today would be able to recognize common seizure types and their impact on people, basic seizure first aid and safety, to be able to recognize when those seizures are definite medical emergencies, and what you can do to provide support to your consumers or loved ones that have seizures. So what is a seizure? Well, a seizure is a brief excessive electrical discharge of the brain. It can alter movement, behavior, sensation, or awareness. Many people don't realize, but there are over 20 different kinds of seizures. And the seizure symptoms depend on where in the brain the excessive electrical activity occurs and how much of the brain is affected during that seizure. The seizures are temporary and episodic. 1 out of every 10 people will have a seizure in their lifetime, 1 out of 10. Many times people know what provoked that seizure, and other times they do not. But what leads to an epilepsy diagnosis is that repetitive pattern. Epilepsy is a chronic neurological condition, and it's characterized by the tendency to have recurrent seizures. Medically, it's defined as 2 or more unprovoked seizures. Because there is a stigma associated with epilepsy, the word is also interchanged with the word seizure disorder. So some doctors don't even call it epilepsy, they just call it a seizure disorder. But epilepsy is one kind of a seizure disorder. When somebody suspects episodes, symptoms, spells, events, We recommend that they go in to see a neurologist. For a child, it would be a pediatric neurologist. And basic diagnostic workup often includes a 2 to 4 hour video EEG, an MRI. They'll draw blood work, and they'll gather information of the symptoms that was clinically observed of witnessing that seizure. Because epilepsy is one of these in the dark type of disabilities, it's so much more common than what people realize. People are very fearful to talk about it, and a lot of people that we work with, some of them are even scared to leave their apartments for fear of how somebody will respond or react to their seizure. But when you look at the incidence and prevalence across the country, there's approximately 2.2 million Americans that live with this condition, which equates to around 30,000 Iowans. 1 out of 100 people live with epilepsy today, but 1 out of every 26 people will develop epilepsy in their lifetime. 1 out of 26. Now, epilepsy is a diagnosis that can happen to any one of us, anywhere at any time. But we see higher onset of the diagnosis in the toddler years, between the ages of 2 to 4, which happened to be the time frame our daughter got diagnosed. We see an increase in the teenage years at the onset of puberty when those hormones are kicking in. And we see it skyrocket in the elderly. The elderly are more prone to brain tumors, strokes, and falls, and all those things could potentially lead to an epilepsy diagnosis. Unfortunately, there's a lot of myths associated with epilepsy. Many people don't realize that most seizures are not medical emergencies. But what is important for you to know, for the consumer that you work with or for your loved one, is to know what's a typical pattern for them. What do they typically look like? Do they have an aura? Do they have a warning prior to their seizure? And so it's really more important to be familiar with that. Many people are not even aware they are having a seizure and may not remember what happened, so don't assume that they do. Many times people, they don't recall anything, and sometimes they don't even believe that they had a seizure after they had had one. Epilepsy is not contagious, but if somebody were to have a seizure in front of children, for example, sometimes they don't know this. And what we see can happen in schools and out in the community is sometimes children will isolate themselves socially from those individuals, and we certainly don't want that to happen. Epilepsy is not a form of mental illness. It is a medical condition. Asthma, allergies, diabetes are all medical conditions. And epilepsy is another medical condition where people need to take their medicine on time, every time, to help manage that condition. Although we do have some people with epilepsy that have a coexisting diagnosis with different forms of mental illness. And the number one comorbidity with epilepsy is depression. It is rare for a person to die during a seizure, but it can happen. It's important to know that there are certain populations of people that are at higher risk. Sometimes it's those circumstances in that area where people have that seizure. For example, if somebody was taking a bath, they could drown in their bathtub. Or if somebody was by a campfire and they fell into the fire. But the number one cause of death in epilepsy is SUDEP, and that stands for Sudden Unexplained Death in Epilepsy. And we were told that our daughter was at high risk for SUDEP because she had multiple types of seizures. Her seizures were not controlled with medication. She also had seizures during the nighttime, during sleep, and the seizures impacted the autonomic function of the brain, which controls the heart rate, breathing, blood temperature. But it is rare for somebody to die during a seizure. A person cannot swallow his or her tongue during a seizure. Some of you may recall, back in the day, they used to teach to put an object in somebody's mouth. Well, they were afraid they were going to swallow their tongue. But the medical professionals say the tongue is a very strong organ in the mouth, and it's physically impossible to swallow. We are worried about that tongue blocking that airway, which is why when somebody is in a convulsive seizure, you turn them on their side, you let that tongue hang out of the mouth, and you let that saliva drain out of the side of the mouth. If somebody were to leave them on their back, during a convulsive seizure, that tongue could block the airway, and that saliva could go back down that throat, and they would be at potential risk for aspirating on that fluid. If somebody were to stick an object in somebody's mouth during a seizure, they could break it off, they could potentially choke on it, they could break their jaw, they could chip a tooth, and a lot of harm could come to that individual. "70% of the time, the cause of epilepsy is unknown." Think about that. If it were you or your loved one, and you're walking out of that clinic with that diagnosis, and 70% of the time, they don't know why. That is very hard and difficult for parents and guardians and caregivers to come to terms with when they get this diagnosis. But for the remaining 30% of the population, they can identify a cause, and many times it'll show up on that MRI. Brain trauma and brain injury are the major identified cause of epilepsy in teens and young adults. The seizures could start right away after that brain injury, or it could start years later down the road, and that's from that damaged scar tissue in the brain, and that's something that a lot of people don't realize. Stroke is the major identified cause of epilepsy in the elderly. Brain lesions is another cause, such as brain tumors. Some people get a brain tumor, they go in, they remove that tumor, and then the seizures start in that damaged tissue around that area where that tumor was removed, and they have to go back in and remove that in order to manage the seizures. Lead poisoning can be another cause, or even infections of the brain, such as meningitis, encephalitis, and measles. Some individuals have brain injury at birth. Perhaps they were born with forceps or a suction cup, or they had apnea, blue spells. Or perhaps they had abnormal brain development right away, such as a congenital malformation such as hemimegalencephaly or cortical dysplasia. Other individuals, on the other hand, are born on time, they have a completely normal developing brain, and then they get epilepsy diagnosis down the road. So it certainly is a spectrum. Now, when you look at traumatic brain injury and seizures, generally speaking, seizures after a TBI can occur early, within 1 week of injury, or it can occur later, weeks, months, years even, perhaps down the road. Now, early seizures should be treated promptly because they can produce further damage to the already injured brain. Now, seizures that occur later, after a long period of time, those that begin at least 1 week after the injury, sometimes they tend to become recurrent, and therefore they are diagnosed with epilepsy. Now, PTE is the acronym for post-traumatic epilepsy. So traumatic brain injury is the most significant cause of symptomatic epilepsy in people from ages 50 to 24. And by definition, post-traumatic epilepsy is a focal or localized injury, and the frontal or temporal lobes are the most frequently affected regions. So prevention efforts for post-traumatic epilepsy include preventing head trauma, that's key, and the preventive use of seizure anti-epileptic drugs, seizure medications, can help decrease the risk of early post-traumatic seizures. However, they may not prevent seizures occurring later on down the road. Now, the likelihood of developing post-traumatic epilepsy after traumatic brain injury is higher with greater severity of the trauma, so such as penetrating head injuries where there is intracranial hematomas or bleeding, depressed skull fractures, or even if somebody is in a coma for more than 24 hours and they have early seizures. Now, about 80% of the people with post-traumatic epilepsy start having seizures within the first 2 years after the injury. Eventually, the risk decreases after 5, and about half the patients with late onset of PTE have remission spontaneously. As is true for non-traumatic epilepsy, MRI imaging often fails to show the cause, and therefore it can be difficult to establish that the epilepsy is post-traumatic. Now, when you look at seizure triggers and precipitants, this is a very important slide. And the reason why this is because if you're working with consumers or loved ones and there are known triggers, there are things that you can do in your home, community, or environment to help make it safer for that individual. Now, when the neurology clinics do the basic diagnostic testing and they do the initial 2 to 4 hour video EEGs, Oftentimes, they will roll in a cart and flash the strobe lights at different intervals, and they'll also try to create hyperventilation, and they'll have somebody blow on a pinwheel or they'll blow in a paper sack. And they look for a response on that monitor to see if those are a trigger. Sometimes people will immediately have seizures. Other times they won't visibly, clinically have a seizure, but they will have a response on that EEG, on that computer screen. If you're working with consumers or loved ones who are triggers to flashing lights and hyperventilation, you need to consider the movies they're watching, the TV they're watching, the computers, all those things can be seizure triggers. Or you want to think about flashing lights when you're doing those community outings. Probably not a good idea to go laser bowling. I don't know if I've ever been to Wells Fargo Arena where they're not flashing the lights all over the place. Now, there is special glasses they can wear. It's a good idea to talk with the neurologist on different protocols that they can do that you can help implement to help manage those environments, because it's going to be difficult to avoid all flashing lights. Now, when you're doing those safety tests and you have to be you're in an environment where all the fire alarms have strobe lights on them now, and so somebody where lights are a trigger, they could be going down in a seizure in the middle of an evacuation process. So you want to think about that as well. Or even if you're transporting somebody in a vehicle, when you drive along, the sunlight coming through the window a certain way as you're driving by the trees, they could have that strobe light effect. Typically speaking, with the flashing lights, it's fluorescent lights or lights that are blinking repetitively. But lights and hyperventilation are not triggers for everybody with epilepsy. The number one reason somebody could have a breakthrough seizure is missed or late medication. This is extremely important. Individuals with epilepsy need their seizure medication on time, every time. A lot of the medication goes straight in the bloodstream, and so if they were to miss a dose or they were to get a dose a few hours late, then they no longer have that medication in their system, and they're much more likely to have a seizure. It's very important because the driving laws in our state falls under the loss of consciousness law with the Iowa DOT, and if somebody has one seizure, they cannot drive in our state for 6 months. So it is very important to make sure that individuals with epilepsy get their medication on time every time. Another trigger is stress anxiety. Suppose you're working with consumers and they're switching houses, or they're switching, you're their job coach and you're helping them find a different job. That individual could be very stressed out about that, and that could be a trigger for their epilepsy, for having seizures. Lack of sleep, fatigue. Some individuals tell me they got to have the same amount of sleep each night. If they have too little or too much, they feel off the next day and potentially ripe for having a seizure. Or if an individual had seizures during their sleep at night, then they didn't get a full night's sleep, and they could be at greater risk for having seizures the following day during class or at work. The onset of the menstrual cycle is a seizure trigger for some females with epilepsy. When somebody is sick, their seizure threshold is lower. If somebody is drinking alcohol or using drugs, those can also be triggers for seizures. Or even prescribed medications. I know there's certain antibiotics that can potentially interact with certain medications, so you got to watch that as well. Overheating, overexertion, this is a big trigger for many, and it was a trigger for my daughter. We would often get the call from school during PE and recess. As soon as she would be running, she would be working up a sweat, and she'd be going down in a seizure. Or think about those individuals who got to walk a long ways. Yesterday it was 90 degrees out. You know, what if they had to walk several blocks to get to that bus stop, to catch that bus, to get to their work? They would be at potential greater risk for having a seizure. Or perhaps they're at home or in the community and there's no air conditioned on that bus, or there's no air conditioned in that home. They could get overheated and potentially have a breakthrough seizure. Or if they exercise too much. A lot of individuals have the gym memberships through their health care plan or through their waiver services. And if some people, if they exercise too long and hard, they could potentially have a seizure if they overexert themselves. Poor diet, missed meals can be another trigger, or even having a full bladder. And we already talked about the extreme hot and extreme cold temperatures. And for some individuals, it's the certain smell that could be the spices that are cooking in that kitchen, in that community home. Or it could be that candle burning in that office next door to where that person is working. Or it could be you're going down the road and the exhaust fumes from the car in front of you. Or you could be in an environment where they're painting the walls and the fumes from that paint could potentially be triggers. Now, for some people with intractable epilepsy, you could manage everything on this list and they would still have seizures. The take-home message is if you're aware of known triggers, just do the best you can do in that environment to help make it safer for those individuals. And in certain cases, a safety evaluation can be done to help determine if any changes can be made. Moving on to seizure types. There are over 40 different syndromes of epilepsy, and as I mentioned, over 20 different kinds of seizures. The seizure symptoms in a specific person are generally the same each time a seizure occurs. Now, some people have auras. Now, an aura is a sign that a seizure is about to happen. It could include, but it's not limited to, an odd taste. It could be a smell, a feeling of fear, a visual, auditory experience, or even a tingling sensation. In some cases, an aura may allow the person to prepare for the oncoming seizure and warn others that a seizure is about to occur. Now, for seizure types, we're going to cover the two most common types of generalized seizures and the two most common types of partial seizures. Generalized seizures impact the entire brain, that a whole brain is involved during that event. What that would look like to you would be the staring spells, the jerking, shaking movements of the limbs, and the drops to the ground. Now, the partial seizures are also known as focal seizures, and they only involve part of the brain. And the symptoms relate to the part of the brain affected. For example, if it's just my left arm jerking, it's just the right side of my brain, that right motor strip affecting that function that's involved in that seizure. The rest of the brain is completely unaffected. The first type of generalized seizure is absence seizures. These are formerly known as petit mal. And these are those quick staring spells. Are they a seizure or aren't they? Because they're very difficult to detect because the signs are so subtle, and these symptoms could be many different conditions besides epilepsy. So when you're with a person, they'll have a pause in activity and they'll be staring off. You're saying their name, Johnny, Johnny, and Johnny's not responding. They have a brief lapse of awareness, and sometimes they may have eye fluttering or a slight head movement or sometimes some mouth movement, but not necessarily. It's very brief, lasting on average 1 to 10 seconds. And people who've been hooked up to a video EEG that have absence seizures, many individuals have hundreds of these today. And when they're in that brief event, they don't remember a thing. So it's kind of like a light switch going on and off. They're in and out throughout the entire day. They're missing snippets of instruction, and they have no idea that they're missing gaps of time, which is why this type of seizure is often confused with daydreaming, not paying attention, and some individuals get a diagnosis of attention deficit disorder. Now, the reason why it's important to get a proper diagnosis and control of absence seizures, because these are generalized seizures. And if they go undiagnosed for a long period of time or not managed with medication, they could potentially lead into the generalized tonic-clonic seizures. Now, these are previously called the grand mal seizure. Generalized means entire brain. Tonic means stiffening of the limbs. And clonic means rhythmic jerking. So it's stiffening followed by rhythmic jerking. Now, initially, the person loses consciousness and they fall to the ground. If they're sitting at a table, it could look like a full forward body drop. As the diaphragm contracts, the person may produce a loud cry. Their eyes may roll up or they may turn to the side, and the body becomes very rigid before the convulsions begin. The person may bite his or her tongue during the seizure as well. And sometimes there's loss of bowel or bladder control, and occasionally there's cyanosis where the skin, nails, and lips will turn blue. Now, if you've ever witnessed a tonic-clonic seizure, it seems like it lasts forever, and that time just stands still. But the average length is 1 to 3 minutes, which is why it's important to time the seizure, because oftentimes people report this event lasting a lot longer than what it actually does because it seems like it lasts longer. Now, when the seizure is over, it's called the post-ictal stage. It's that recovery stage. The individual is very groggy. They're moving their head. They're confused. They're disoriented. They may be complaining about migraine or headache. Their muscles are sore. If they're trying to talk, their speech may be slurred, may not be making sense, and they're just totally wiped out. Our daughter had all of these symptoms post-seizure, plus she couldn't walk because her seizure started in various areas on the right side of her brain. They would quickly generalize, and her whole left side was just limp. So the recovery time is different for everybody. In our case, for our daughter, we would have to pick her up, take her to her room, and she would need to sleep it off for usually about 2 to 3 hours. If we had to wake her up because we had to prematurely wake her up because we needed to go somewhere, then she was just out of it. She could hardly function. But if we let her wake up on her own, then it was kind of like the brain knows how long of a time it needs in order for it to reset itself. And then usually she was good to go again. It's just that on some days the next seizure would happen pretty quickly after she recovered from the previous one. So what do you do if you witness somebody in a tonic-clonic seizure? It's very important to stay calm. You want to track the time. And the reason why tracking the time is important, because if that seizure lasts longer than 5 minutes, then it will require emergency intervention. 5 minutes is longer than the average length of seizures. And so that's why the doctors want to know how long did that seizure last. And when you time the seizure, you don't count the post-ictal stage, the recovery stage of the seizure. You stop the timing when the seizure is over. It's important to reassure other people and to explain what is happening if necessary. You want to turn the person on their side to keep the tongue from blocking the airway, and it allows the saliva to drain to the side of the mouth. Now, either side will work, but the medical professionals prefer the left side because the way that the hardest positions allows for easier breathing. You want to cushion the head. Well, you may not have a pillow nearby. You grab a coat over there or on that chair or grab that bag. And if you have nothing around, you can cup your hand and put your hands underneath that head to cushion the blow from that head hitting that hard concrete or surface. You want to remove hazards out of the way, the tables and chairs and sharp objects, because as those limbs are jerking and shaking, you don't want any other injury to come to that individual. If they have glasses, you want to remove them. If they have a coat on, you want to loosen up the zipper, loosen up the buttons towards the top of that coat. You want to keep that airway as open as possible. Now, if it's a larger size individual and they're in a chair, if they're a child, if it's safe to ease them to the ground to their side, then do so. But for a larger individual, there are going to be many circumstances where they have seizures on stairs, in chairs, or wherever where you're not going to be able to get them to the ground on their side. You don't want to pry the person out of that environment. You want to support the head so the head isn't tipped forward or back to keep that airway as open as possible and to make sure that saliva is draining out of the side of the mouth. And just follow basic seizure first aid protocol. You just got to do the best you can do given the circumstances of that environment. The seizures literally can happen anywhere and any time, and many times there's no warning at all. And it's important to document the seizure activity in your records. If you're an agency, or document it in your seizure tracker or My Epilepsy Diary are two forms of apps that a lot of families like to record their seizures for their physicians. Now, if you're working with a wheelchair user and they have a seizure in the wheelchair, again, you got to do the best you can do. Generally speaking, you don't remove the person from the wheelchair unless absolutely necessary. You want to put on the brakes to prevent movement. You want to keep their seat belt and their straps on if they have leg straps, but you want to loosen them up. Some people's seizures are so violent they could potentially bust right through those. You want to protect and support the head. And again, make sure the airway is open as possible. You want to cushion underneath the arms to prevent further injury when their limbs are hitting that hard wheelchair armrest. And basically follow basic seizure first aid protocol. Again, you just got to do the best you can do given the environment and circumstances. Now, what if you're transporting a consumer and somebody has a seizure in a vehicle? Well, this happened to us many times. And if it's safe to pull over and stop, then do so. But I will tell you, there will be situations if you're in heavy traffic in a large urban area or on the interstate during rush hour where you're not going to be able to pull over and stop. Now, if you're on public transportation, they're going to have their own protocols. But if you're in a suburban or a vehicle where there's a bench seat or on a bus, if you can turn the person to their side, you want to face them away from the back of that seat or in the aisle if necessary, and basically follow basic seizure first aid protocol until that person regains consciousness. Now, if you're in a minivan and they're in one of those captain chairs, you can recline the seat back and then turn the person on their side in that seat. But many times it's going to be difficult to move them anywhere because you're going to have a vehicle full of consumers or full of passengers. Now, what if you're with a consumer and they have a seizure in the water? This is very serious. We were caught in the water twice with our daughter in seizures, and it was very scary. You want to support the head so both the mouth and the nose are always above water. It may take another individual to help. You want to remove the person from the water as soon as it can be done safely. Now, if the person is not breathing, then that's the one time the medical professionals recommend rescue breathing. Now, always transport the person to the emergency room, even if they appear fully recovered, because there is a high likelihood that they could have potentially aspirated water. And it's important to find that out sooner than later. So the two most common types of generalized seizures we discussed are absence seizures, the staring spells, as well as generalized tonic-clonic seizures. Now we're moving into the two most common types of partial seizures. Simple partial seizures. This is a seizure where full awareness is maintained. And the signs are so subtle that most of the time people don't even know that that's a seizure as well. So it could look like rhythmic movements. The person could be describing isolated twitching of the arms, face, or legs. Or that person could be describing sensory symptoms, such as an odd tingling feeling, or their leg is weak, or they'll say, do you hear that ringing noise? And there's no ringing noise in that environment. Or we had somebody in one of our groups one time, they said, well, do you smell that skunk? And there was clearly no skunk in that library meeting room. But yet that person said when they smelled that skunk smell and they're hooked up to the video EEG, it showed up as a simple partial seizure. The consumer could be describing a funny taste in their mouth, only they just didn't get done eating at the lunch cafeteria. Or they could be describing an upset stomach, only they're not sick. Or somebody could be describing a visual distortion. I was with an individual a few years ago, and I knew this person had simple partial seizures, and we were walking down a hallway, and they were painting the walls. The fumes from that paint triggered the seizure. And then he said, I'm going into my seizure. And I knew they were simple partial, and because he has full awareness, I asked a lot of questions because they can talk and walk during these events. And I said, well, do you want to go in that room and sit down? And he said, yeah. So we walked into the room, we sat down, and then he said, there goes my vision. And I said, well, what do you mean? And he said, I've lost 90% of my vision. I see all colors of the rainbow. I can hardly see a thing. There were people sitting in the waiting room over here. There was a secretary over there. And to them, it looked like two people walked in, sat down, carried on a conversation, and they had no idea he was in a seizure. For other people, it's psychic symptoms. They're explaining deja vu, hallucinations, a sudden, or perhaps they experience a sudden feeling of fear or anxiety, and nothing precipitated that in that environment. For some individuals who are nonverbal, if they experience these odd sensations or sudden feeling of fear, and there's nothing that precipitated that in that environment, sometimes they can play out as behavior. These events last less than a minute, but obviously it can be confused with somebody acting out or chalked up as behavior issues or even being a mystical experience or psychosomatic illness. No particular first aid is needed other than emotional support and reassurance because they're fully conscious during this event. Another name for a simple partial seizure is that aura I talked about. So when people feel these odd sensations, and they feel a seizure coming on, technically it's a simple partial seizure. So these odd sensations, odd movements, odd symptoms, they can come and go, or they can come and secondarily generalize into a bigger event, such as a tonic-clonic seizure. So the true way to know, these symptoms could look like many different things. Some people say, well, that's what my migraines look like. Well, sure, migraines aren't epilepsy. So these symptoms could be a host of multitude of other medical conditions. These are the symptoms for simple partial seizures. And the best way to know if these symptoms are a simple partial seizure is if they experience these symptoms while they're hooked up to the video EEG, because then the data will show if it's a simple partial seizure or if it's potentially something else. So a simple partial seizure, people can walk and talk. But a complex partial seizure, people can walk but not talk because their consciousness is impaired. So they don't have that ability to respond. And so what this one looks like is people start staring off. They have a lot of repetitive purposeless movements. They're wandering aimlessly with no sense of direction. They're just walking clumsy and disoriented. They're getting reprimanded because they're not responding to questions, they're not paying attention, you know, and they're picking stuff up and dropping them down. Or if somebody's holding a pop bottle or a water bottle, they could be tapping their finger repetitively on that bottle. Sometimes they're trying to talk and their speech isn't making sense. Other times they could have lip smacking. And on average, it lasts 1 to 3 minutes. And when they come out of it, when they're in that recovery stage, they're very tired. People describe having a headache. Sometimes people are very nauseated. Some individuals tell me that they vomit after these events. And so the thing with this one is if consumers or individuals feel threatened in any way when they're in this state, it's a natural reaction for them to fend off, to push back, and you could potentially get aggression on your hands. So if somebody's walking around disoriented, they're not responding to questions, they're pushing back, getting aggressive. That is why this seizure is oftentimes confused with somebody being drunk or using drugs, because unfortunately that's what it looks like to the traditional bystander. Or it could be chalked up as aggressive behavior. Now, complex partial seizures usually begin before the age of 18, and they are the most common seizure type in teenagers and adults. In a complex partial seizure, so somebody can start having a complex partial seizure and it can also progress to a generalized tonic-clonic seizure. So here's another slide on partial seizures. So I like this because the different symptoms people exhibit, that gives the doctors an idea of what brain function is involved during that seizure. For example, I described the tingling feeling in somebody's leg. Well, that means the parietal lobe is involved during that seizure. Or remember when I mentioned the flashing lights as a trigger? That means the occipital lobe is involved in that seizure. Or how about that strange skunk smell? That would be a function of the temporal lobe. Or what if the eyes and head were turned to the side? That's a frontal lobe feature. Now, you don't need to memorize all the symptoms and all the different brain functions and where they come from. But the purpose of this slide is to show the importance of documentation. And the reason why it's really important to mark down the symptoms that you observe during seizures is because so that family member or guardian can get that to that neurologist. And the neurologist can look at those symptoms and have an idea if, the focal seizures are now generalized seizures, or if it started in one part of the brain and now a different part of the brain is involved that wasn't affected before with their seizures. And that helps the physician to better manage the seizure medications and other seizure management treatment options to help manage those seizures. Now, what do you do if you see somebody in a complex partial seizure? Again, you want to stay calm. You want to reassure others. You don't want to be yelling seizure, seizure, and creating unnecessary chaos in that environment. You want to track the time. The key for this one is do not restrain. So if somebody is wandering, you want to close the door. You want to let them wander in a safe place. If you're outside in a parking lot, there's traffic and there's other individuals, have people stand in a circle. Let them wander safely in that circle. But the key for this one is gently guide. You want to guide them away from hazards. You want to walk between them and that brick wall. And so it can be tricky on gently guiding and keeping them safe, but yet making sure that they don't feel threatened in that overload environment. Sometimes during seizures, if there's other consumers or children or students in the room, another adult will remove all the other individuals to kind of keep that calm environment. But just because the person can walk, don't expect them to obey verbal instructions, because they can't. And again, if the seizure lasts longer than 5 minutes, then that's what the medical professionals determine as that emergency protocol. Overall, dangerous first aid. Never, ever put an object in somebody's mouth during a seizure. The medical professionals say, it's physically impossible to swallow your tongue. That is very, very important to remember, because that is the one big teaching that has changed over the years. Restraining or holding someone down during a convulsive seizure can cause spraining or breaking of body parts, so we don't want to do that. And do not attempt to give them a drink of water. Say, here, do you want a drink of water? They would be at potential risk for choking or aspirating on that fluid. Now, the one exception to this rule is there's one rescue medication of a liquid that you squirt in the buccal membrane of the mouth to help stop that seizure, but that's only for certain individuals through a doctor's order for certain types of seizures. And that would be the only exception to that rule. Some of you may have heard of intractable epilepsy. And what that means is that person has failed to respond to medications and other treatment options. Sometimes individuals will have structural brain or neurological conditions, and it is by far the greatest challenge to achieve seizure control. Now, status epilepticus, going into status, this is something that the doctors, or it's a good idea to know if that consumer or loved one has ever been into status. Well, what that means, medically defined, is 30 minutes of uninterrupted seizure activity. So that could be one seizure going on and on and on that does not end on its own, or it could be the person clustering with their seizures, having multiple seizures without recovery to baseline. This is a definite medical emergency, and it requires immediate action to stop the seizure. Every person or every consumer, every student, they should have a seizure action plan that clearly defines what is a seizure emergency for that individual and what the emergency response plan is, and that comes straight from their neurologist. Now, most doctors nowadays, they consider going into status when that seizure hits 5 minutes in length. And so the Epilepsy Foundation recommends that emergency response protocol be activated if a person has been seizing for 5 minutes with no sign of stopping. And generally, that's when the physicians will write that, is when that seizure hits 5 minutes, because again, it's longer than the average length of seizures. Now, what is a seizure emergency anyway? Well, for sure, it's the very first time somebody has a seizure, or if somebody has an event and no medical ID or no known history of seizures is known. Again, if that seizure lasts longer than 5 minutes, if that person clusters with their seizures. Sometimes with our daughter, she would have seizure, she would sleep, she'd get back up and do things for a couple hours, and she'd have another seizure and sleep, and by the end of the day, she was having seizure after seizure, and she wasn't fully recovered in between. And so usually that's when the doctor would recommend that we administer rescue medication to help settle things down for a while. If that your loved one or consumer has more seizures than usual, or they have a change in type, there could be something else going on in that brain. So usually it's a good idea to get that checked out. If the person got injured during that seizure, or if they also have diabetes or pregnant, those are serious coexisting conditions that need to be checked out. We talked about the seriousness of seizures occurring in water, and also the normal breathing should resume after the seizure. If they turned blue and have shallow and labored breathing, when the seizure is over, they should pink back up and their normal breathing should resume. If it does not resume, that's a definite cause of concern. And emergency services need to be called. Now, non-epileptic seizures. These are events that look just like epileptic seizures, but when they're hooked up to the video EEG, they have no correlation, meaning they have a normal brainwave reading. I've had people bring in their discs showing me their convulsive seizures, and it looks just like my daughter's convulsive seizures. But when they're hooked up to that video EEG, it has a normal brainwave reading, and they're non-epileptic. Other words you may have heard of this called is psychogenic seizures or pseudo-seizures. Sometimes we see servicemen coming back from war experiencing such trauma with bombing that they relive that in their brain to the point where they're having full-blown seizures. We don't like to use the word pseudo-seizures because some people describe that as faking it, and they're not faking it. It's hard for those to manage. And the reason, and the video EEG is the most effective way of diagnosis if that seizure is an epileptic seizure or non-epileptic seizure. And the reason why this is so critically important is because the treatment options are different. If it's epilepsy, they need to be on medication. But non-epileptic, medications won't do any good, and they need to see a counselor to help them overcome that condition. Some people have both epileptic and non-epileptic seizures, and those can be very difficult cases to manage. Now, in some studies, they indicate that as many as 20% of the teen and adult patients referred to comprehensive epilepsy centers for study with video EEG are found to actually have non-epileptic seizures, which are psychological in nature. Now, treatment options. So there is no cure for epilepsy. And for the purposes of the slide, AED stands for anti-epileptic drugs and not automated external defibrillator. And PR means according to circumstances. So the frontline treatment is medication by far. Approximately 2/3 of people with epilepsy that will have adequate seizure control with that first or second medication. Now, if the first 2 seizure medications fail, it's unlikely that third medication will work. And then the doctors are looking on to see if they're a potential candidate for brain surgery. Or if they're a child, they're looking at the ketogenic diet. And if those aren't options, then they look at the vagus nerve stimulator. Now, for some individuals, the doctors will recommend rescue medication, oftentimes in children, not quite as often in adults. But just so you're aware of what rescue medications are out there, the rectal diastat is the diazepam gel, and it's FDA approved for anyone to give, but it's a rectal, and it can be very difficult from a privacy standpoint administering this rectal diazepam in the public. There's one clinic that likes to recommend the lorazepam, or the liquid you squirt in the cheek of the mouth. And for some individuals, every time they do that, it stops the seizure. Several clinics across the state of Iowa have switched from the rectal diastat to the intranasal midazolam. And you draw it up, and then you put the atomizer bulb on it, and then it nifs up the nose. It's cheaper, it's easier to do in all different types of environment, and it's quicker acting. Now, they don't really use the tablets anymore. They used to put tablets in the cheek of the mouth, but the problem with that is the choking hazard, and it wouldn't dissolve as quickly, and it wouldn't stay where it needed to be near that buccal membrane. Typically, the rescue medications are recommended for individuals that tend to go in, that are at risk for going into status epilepticus, or for certain seizure types that would potentially last longer than what they normally would. Now, the vagus nerve stimulator, a lot of the adult population with intractable epilepsy has a vagus nerve stimulator that's a pacemaker type of device that's implanted under the skin in the upper left chest. There's wires attached that coil around the vagus nerve, and it provides stimulation to the brain. It's one of these devices that they don't quite know how or why it works. They just know in some people with epilepsy, by providing that stimulation to the brain, it helps manage their seizures and decreases the severity and intensity of seizures. So the device has a computer chip and a battery, and it's always implanted on the left side. There are rare cases, like if they have a shunt on that side in their brain, then they would have to put it on the right side. But it can stop a seizure in progress by firing its impulse. And so when somebody gets a vagus nerve stimulator implanted, they usually leave it turned off. Then after a couple weeks, they turn it on. Then they go back, and there's going to be a lot of trips to that neurologist, because each time they go back, they'll slowly increase the settings. Now, some people it helps a lot, and some people not so much. A lot of people in our support groups across the state have these. And I will tell you, they're nice because when somebody goes into seizure, I just take that black magnet and I swipe it over the chest. And so it's labeled, it has an indication for epilepsy and it has an indication for depression, but usually they only put it in if you have epilepsy. And since depression is the #1 comorbidity with epilepsy, then that's why it can help a lot of people. So it can either come with a wrist strap or a belt clip. And if you're working with consumers, the consumers can ask their physician for extra magnets so you can keep one in at home or keep one with you. Some of our individuals with epilepsy have memory challenges and sometimes forget to bring the magnet. So if somebody were to have a seizure, you would swipe that magnet once right over that upper left chest where that battery is implanted. And I've swiped them in people, and I've seen it stop the seizure. I've swiped them in people. I've seen it decrease the severity and intensity. And I've swiped it in people, and I've seen it done absolutely nothing where the seizure's still intense. Usually those are the cases when they had just got it implanted. And if that's the case, you wait 1 minute and you swipe again if needed. It doesn't hurt them. When you swipe the magnet, it just triggers and it provides stimulation to the brain. And it's the way the pulse generator is triggered, the physician programs it to go off every so often. And so when you swipe the magnet, it just triggers it, hoping to help stop that seizure. So overall factors that impact people with epilepsy include the seizures, the medication side effects, if they have brain abnormalities, coexisting conditions, attitudes, beliefs, experiences. All these things can impact the learning, the behavior, self-concept, stigma, psychosocial development over quality of life for the person with epilepsy. Many people with uncontrolled seizures have a difficulty in learning, memory, and concentration and attention. Many people, they have a seizure and they don't remember anything that was talked about or told to them earlier that same day. And so know that with the person you're working with, if you have to repeat things, or it could take a lot of repetition. And so know that work may have to be retaught. And also know that learning problems can persist even if the seizures are controlled or managed. And if they're going through medication changes, up or down on the meds, they could be drowsy, they could be not paying attention, having extra concentration difficulties or behavior changes during that change. People with epilepsy are more likely to suffer from low self-esteem. And that's because, think about it, if you don't know when and if a seizure will occur, it's very scary for individuals. And so it has a big impact on psychosocial development. And so it's always a good idea to have a person with epilepsy to see a counselor to help talk through those different things, because many people with epilepsy fear dying from the seizure, suffering brain damage, having a seizure in public, losing control, or losing their friends. And it's a good idea to see a counselor. So overall tips, what you can do to support people with epilepsy: stay calm during the seizures, be supportive, be familiar with the person's seizure types and their seizure action plan, and be familiar with the seizure triggers so you can help better manage that environment to make it safer for those individuals. I usually don't take the stairs. I take the ramp, I take the elevator. When I'm looking at housing for people with epilepsy, I always try to find ground level housing. People who have stairs in their apartments, they're always having seizures on stairs, especially if they have intractable epilepsy. And so you just kind of want to keep it as safe as possible to decrease those injury risks and encourage positive peer interaction. Consumers, adults, children with epilepsy, they all have every right to interact and to participate and to live in the community, to be in the community, to work in the community, just like everybody else. And they shouldn't be discriminated against with their epilepsy. Now, if you go to the Epilepsy Foundation YouTube channel, we have several videos. I encourage you to watch this one. The link is right there, and you can watch it immediately after this webinar. It's called Understanding and Assisting People with Epilepsy. It's a nice summary of what I went over today, and plus it shows actual different types of seizures. Other resources you may find helpful: our national office, the website is epilepsy.com. They really have a great depth of credible information on different epilepsy syndromes to different ages of epilepsy to everything. You can search on that website and find anything and everything that, if you're looking up specifics for epilepsy for your loved one or consumer. Our Iowa website is epilepsyiowa.org, and that's where we have a listing of all of our programs and services and advocacy efforts and upcoming events. The Center for Disease Control website, the CDC website, and the NIH, the NINS website has great information and papers and publications on epilepsy as well. And with that, that's my contact information. I do the seizure trainings in Central and Western Iowa. We have a staff in Iowa City that conducts seizure trainings in Eastern Iowa. And we're here to help consumers and organizations and professionals and families better support and better learn how to help people with epilepsy. So with that, Annie, I will turn it over for some questions.
Thank you, Roxanne. That was great. While I'm letting people kind of finish putting in your questions, feel free to do that now. I just want to remind everybody to please reach out to the Brain Injury Alliance of Iowa if you are in need of any brain injury-related resources or information. Our Neuro Resource Facilitation Program is designed to help connect individuals with brain injury along with their loved ones and the professionals that serve them to needed supports and services in their communities. And we are always available to provide case consultations to professionals if you have a client with a brain injury and you are looking for resources or support in figuring out what to do, which direction to go. We are also able to provide general training opportunities on brain injury as well. So please feel free to reach out to us if you are in need of us. So a couple of questions that have come in. Let's see. Courtney is wondering if the recovery period of a generalized tonic-clonic seizure, is it possible for that to look similar to a complex partial seizure as they're in that postictal state?
Wow, that's a good question. So that would be a great thing to record those symptoms to share with that person's neurologist. And what a lot of neurologists like is, now that a lot of people have cell phones, they recommend videotaping that seizure or videotaping that recovery stage and emailing it to them or showing them what you're seeing. Because sometimes it's hard to describe in words what you're seeing when you're trying to explain it to a physician. So everybody's recovery is different. And I think that would be best for that individual, what you're seeing, to ask that to that person's physician. And sometimes the only way to know is when they're in that recovery stage or whatever symptoms you're seeing. Is if you can capture it when you're hooked up to a video EEG, then the medical professionals will be able to tell you, yes, that's a definite, that seizure is still going on, or no, that seizure is ended and they're in that recovery stage.
Perfect, thank you. And then another question is, those comorbidities that you mentioned, are those triggered regardless of the awareness of the seizures? If someone, so like depression or self-esteem, so if someone wasn't aware they were having seizures, would those kind of coincide, do you think? Does that have an effect on it?
Well, typically with the comorbidities, they're separate diagnosis, separate from the epilepsy. So as I mentioned, epilepsy itself is not a mental illness, but people may also have other conditions with their epilepsy. Other examples would be autism. Approximately 30-35% of people have a diagnosis of autism and they have a diagnosis of epilepsy. Children who have ADHD, 40% of that population will also have epilepsy. Individuals with an intellectual disability, about 30% will also independently have a diagnosis of epilepsy. So what it really boils down to is if there's anything abnormal neurologically with the brain, that individual is at potential greater risk for developing seizures and or epilepsy down the road.
Thank you. I don't think we have any more questions at this time. So Roxanne, do you have anything else that you'd like to add before we end the session?
No, I just thank you, everybody, for participating on this call today, and continue to utilize the Brain Injury Alliance as well as ourselves to help address those challenges that may come along the way with epilepsy and brain injury.
Thanks, Roxanne. And just as a reminder to everyone, the webinar was recorded and it will be saved on our website the next day or two. And after we end the session, you will get an email with your certificate of attendance with a link to a survey for your feedback on the webinar. I just want to thank everybody again for attending, and thank you, Roxanne, again, and I hope everybody has a great rest of your day.
All right, thank you. And then also the Iowa Seizure Smart Conference we're holding is November 5th in Coralville, and we have neurologists and medical experts lined up to speak and address a lot of the issues that impact epilepsy. So thank you again, Annie.
What are the dates on that? Can you remind everybody?
November 5th, 2016 in Coralville, and you can get information on our website or social media sites.
All right, well, thank you, Roxanne. Have a good rest of your day. Thank you, everybody.
Thank you, Annie. Bye.